Good evening, good morning, everybody, depending where country you are. It is my pleasure and honor to introduce Dr. Louis Al-Faraje tonight. He will talk about alveolar ridge expansion by split-cortical bone. And his impressive CV. He's a private practitioner as well as the founder and director of the California Implant Institute, which offers continuing education through advanced surgical and prosthodontic programs, including a master program and live patient surgical externship. Since 2001, more than 2,000 dentists from over 20 countries have received training at the Institute. He's also the founder of Novadontics and all-in-one implant practice management platform. Dr. Al-Faraje studied dentistry at Kiev Medical Institute and at Loma Linda University in California. He is a fellow of the American Academy of Implant Dentistry and a diplomate of the ICOI. Now, Dr. Al-Faraje lectures nationally and internationally. He will show us today the splitting technique, and I'm very proud and happy. I want to thank Dr. Al-Faraje for his engagement in the ICOI, especially in our diplomate program. And more information you will get very soon from the ICOI. So thank you very much, Louis, and enjoy the lecture. I will stay with you until the end with the questions and answers. Thank you.
Thank you, Adi, for the introduction, and it's a pleasure to work with you and with the ICOI. Good morning or good evening, everybody. It's my pleasure to be with you. I'm gonna go ahead and share my screen. Greetings from San Diego, California. It's noon time here today, Saturday. And I'm Dr. Louis Al-Faraje, the academic chairman of the California Implant Institute. This is the headquarters in San Diego, California, where we provide some lectures and hands-on programs. In collaboration with the UNLV Dental School, we provide online fellowship program and Zygoma hands-on cadaver program starting next year. And we do provide live patient externships in Rosarito, Mexico, and starting next year in Port Vila, Vanuatu also. We've been doing this for 18 years, live patient courses for 8 years. And this is 2 of the 10 operatories that we have at the Mexico facility for the hands-on programs. I'm the author of these 4 textbooks from Quintessence Publishing. So today's topic is alveolar ridge expansion by split-cortical technique. And we would learn the indications to do this procedure, step-by-step protocol, possible complications, how to deal with them. And I'll give you plenty of clinical tips on how to perform predictably this procedure. So the definition of this procedure, we are expanding the narrow maxillary alveolar ridge by longitudinal bony cut, if you will. This procedure increases the amount of available bone for the placement of implants. So obviously, like any bone grafting procedure, the goal is to gain adequate height or width, or both height and width in the alveolar bone, so we are able to place implants simultaneously or as a delayed stage after the implant placement. This procedure was introduced in the literature for the first time by Simeon, Baldoni, and Zaffe in 1992. It was not exactly how I'm going to introduce it to you if you are not familiar with, but the expansion of the maxillary bone was introduced, if you will, in this article. This procedure is possible because the maxillary ridge, the maxillary alveolar bone is really elastic and to a certain degree is bendable as long as we follow certain rules, certain techniques in doing so. And it is a really very predictable procedure. The learning curve of this procedure is very short. As long as you follow some advices I'm gonna tell you, especially for the first few cases, until you develop some hands-on experience with it. But as you will see, this is really fairly simple as long as you do it for patients who are candidate for it. Any procedure really is simple as long as the patient is a perfect candidate for it. Problems start to happen when you are enforce a procedure on a patient who is not candidate for that procedure. That when usually it's very challenging and the chances for complication, the chances for failure is quite high. So you have to pay attention to the indication, what patients are a candidate for this procedure. Number one, this procedure is only for the maxilla. For the mandible, we have to expand to ridge split the mandible. It's a different procedure. It's called the pedicle sandwich plasty, PSP. And this is not what we are covering today. So what we are covering today is exclusively doable for the maxilla. I put here anterior maxilla because it's really between maxillary sinuses. So it can be between number 4 and number 13. So between the two second premolars. Of course, you do not have to have fully edentulous maxilla in order to perform this procedure. However, if you've never done this procedure before, the chances of you doing it with no complications, with very low chance of complications, is if the patient is fully edentulous. So my advice is you do it initially few times for fully edentulous patients because you have less stress on the bone as you are expanding the maxilla, and accordingly chances of complications is very low. Number two, and we will talk about that in more details in a second, appropriate alveolar ridge resorption pattern. So not only maxilla being a maxillary bone is not enough. We need to have appropriate ridge resorption pattern. We'll talk about that in a minute. And then minimum 5 teeth edentulous span. Again, we are bending hard tissue and it is bendable, if you will, but that does not mean we can bend the bone or expand the bone if we have only lateral incisor missing, for example. This procedure would not be indicated. So the bigger the edentulous span, the better it is, the easier it is, the more flexible the maxilla is. So I picked that number. It's not like it is in literature that you have to have 5 teeth edentulous span in order for this procedure to work. But from my vast experience in this particular procedure, 5 teeth, I would say, is about the minimum where you can do good amount of expansion using the split cortical technique without chances of cracking, if you will, the buccal plate. Then no height deficiency. So obviously this procedure is only for gaining, we perform it only for gaining width. It will not help you in gaining any alveolar bony height. So if the patient has not adequate height for implant placement, this procedure also not indicated, even if all other conditions are met, because it will not do any good for increasing the height of the alveolar bone. Now, we have deficiency in the width, and you think this procedure is indicated. Well, again, one of those conditions, we have to have roughly 4 millimeter of cristal width after reasonable alveoloplasty, meaning we can start doing this procedure even with knife edge cristal bone, but after reasonable alveoloplasty, it's not like we have to lose half the maxillary alveolar bony height in order to get to those 4 millimeters. Then we have another problem on hand, which is probably inadequate alveolar bony height to place implants. So we would like to get to 4 millimeters either from the get-go, if you will, or after a very reasonable amount of alveoloplasty. So a couple of millimeters of alveoloplasty, 3 millimeters of alveoloplasty, maybe even a little bit more if you have plenty of height under the nasal floor, etc. And you have to get quickly to 4 millimeters without compromising the what left over, if you will, from the alveolar bony height for the placement of the implant. And then, of course, doing this procedure for crown and bridge work, it's a little bit challenging because the bony papillae and the soft tissue papillae are gone a long time ago. That's why we're doing this procedure. And doing crown and bridge work, although I'm going to show you a case where I did crown and bridge work in conjunction with this procedures on implants that were placed with this procedure. But obviously the right thing to do here is do this procedure when the goal, the final prosthetic goal, is a hybrid or FP3 type prosthesis. So I created a classification that was published in my anatomy book regarding the bone resorption pattern. We all know that when we lose teeth, initially you lose alveolar bony width, and then you lose alveolar bony height until you don't have, obviously, until the patient does not have any bone left in the alveolar bone. However, I noticed one day, after looking at hundreds of scans, I couldn't help it, but I noticed that this is not exactly right or true or accurate for everybody. So I came up with this classification that will help you selecting the proper bone grafting procedure per the type that you have or the stage of the bone loss. So look at the left-hand side as the class 1. The patient just lost his or her teeth, and we still have plenty of bone in height and width. And then after very quickly, you will see that we're going to start losing bony width, alveolar bony width. But then if you pay attention, you will see that, let me see here, I think I need to move this right here. All right. And then very quickly, you will see that not all patients are the same. Not all alveolar ridges resorption patterns are the same. On the, for class 3A, you see a knife edge at the crest, but then very quickly, you have like a triangle shape, as you can perfectly see from the illustration. And this is preferable. This is nice resorption pattern because a little bit of alveoloplasty. And guess what? Not only you can do ridge expansion if you have other conditions met, you know, being maxilla and long-term edentulous span, etc. Not only that, but you have other options. You might be able to place implants without any bone grafting procedure simply by doing some alveoloplasty. Now on the class 3B, as you can see, not only it's a knife edge at the crest, but unfortunately for these patients with a class 3B type bone resorption, many procedures would not be helpful. I mean, you can do alveoloplasty, 10, 15 millimeters of alveoloplasty, you will still not gain adequate width to place implants. You can do many millimeters of alveoloplasty, bone reduction, alveolar bony height reduction. You would still, the patient would still not being a candidate for the procedure we are covering today. And then, unfortunately, if it is class 3A or class 3B, eventually, if nothing is done, the patient will arrive to class 4. If you will, and that's when you have inadequate bony alveolar bone in height and width, and that's a problem and very challenging. And the bone grafting procedures indicated for those are different from what we're covering today. So what we're covering today requires that the bone resorption pattern is class 3A. For the maxilla, it's the same. For the maxilla, for the mandible, I'm sorry, it's the same classification. So if you pay attention to CT scans, you will see after minimal resorption pattern in width, patients will take on two different routes, 3A or 3B, before again they arrive to class 4, where we have a gross deficiency, if you will, in alveolar bony height and width. So this is a proof of what I'm telling you is what it is in real life. You take CT scan on patients, and especially in the maxilla, you should really not rely on what you see. You should look at the CT scan, because the soft tissue in the maxilla, the gum, is very thick, and quite often you have very little amount of alveolar bone left. Yet, looking in the patient's mouth, you might think you have all the bone in the whole world to place implants, and then you open flap and you discover that it's really a huge problem on hand. This will not be the case if you have a CT scan before surgery, and you will take your time to evaluate the alveolar bone, what you have available under the gum. And as you can see here, for the patient on the left-hand side, if you do alveoloplasty, it will not do you any good. You can remove 2/3 of the alveolar bone, as you can perfectly see, and you still don't have adequate width to place implants or to do even alveolar ridge expansion. On the right-hand side, however, you can see that it is knife edge crest, just like the case on the left-hand side, yet with a little bit of alveolar bone reduction, you can gain quite a bit of width. You might possibly place implants right away without any bone grafting procedure. Definitely expansion is indicated. Definitely block grafting is doable, because you have plenty of bone to place a block and to fix the block using the bone graft fixation screws, etc. So you need to make sure that all those conditions that we put on the screen here, that are met before performing this procedure. It's extremely simple procedure, as you're going to see in some sample cases I'm going to show you, and in a video that we're going to run. It's fairly simple, very low very short learning curve, but I want to emphasize that it has to be done not only on your first few cases, but forever in the future when the patient is candidate for it, just like any other procedure. And we need to make sure not only it's maxilla, but we have the appropriate alveolar ridge resorption pattern that we talked about, plenty of edentulous span, so we have less stress as on the bone as we are expanding it, as we are bending it. No height deficiency, a good amount of crystal bone after reasonable alveoloplasty, and the prosthesis should be hybrid. So I can't emphasize enough to do a procedure for a patient who is candidate for it, because it will go very smoothly. It will go by the book. It will be a textbook procedure, and you will have a shorter learning curve, and you will have less possibility of complication. Procedures, any procedures, not only this one, need to be done for patients who are candidate for it. Otherwise, you are asking, you are begging for problems, and you do not have to beg very hard. So back to the procedure, we need to make sure on the CT scan we evaluate all anatomic landmarks that are pertinent to this procedure, to that region where we are doing this procedure. So the nasal floor, the topography of the nasal floor, and the infraorbital nerve bundle, take that in consideration, and how close it is. And then take it in consideration when you are making the releasing incisions, as not to cause any numbness to the upper lip, because as you can see here, this is the area that partially, in conjunction with facial nerve, innervated by the infraorbital nerve, which is a branch of the maxillary nerve. The maxillary incisive canal, location, size, how close you can get to it. Quite often in conjunction with this procedure, we do incisive canal deflation because we definitely would like to place implant in number 8 or 9, meaning the central incisors, and quite often the canal is very big, and we are doing this procedure at the same time, and we absolutely need to place implant in the first, in the central incisors, either of them or both of them, due to not possible to place adequate number of implants without utilizing these locations. Then quite often with this procedure, we do incisive canal deflation, that to be covered maybe in another webinar in the future. So this is the cross-sectional slices, and you can see different shapes of the maxilla, and knife edge with adequate bony width very quickly as you are doing reduction with alveoloplasty. So let's go over step by step, since we don't have that much time. Let's go step by step over how to do this procedure. So we numb the patient. Look how simple it is. We numb the patient, and infiltration would do on both sides, on the buccal and the palatal side. And now we need to open a full thickness flap. So mid-crestal incision from molar to molar, from second molar to second molar, in case the patient is fully edentulous, and of course releasing incisions in that area. So classic Lafort one, if you will, incision, full thickness. And now we need to do alveoloplasty if, I repeat, if the alveolar crest is fairly pointy, knife edge. So that step number 3, flattening the alveolar crest in order to gain that minimum amount of width that I mentioned earlier of 4 millimeters, not necessarily needed every single time. Quite often, I open full thickness flap and I start splitting the ridge with the piezosurgical unit without the need for alveoloplasty. So quite often, I would say more often than none, you need to do some flattening, some bone reduction, but not necessarily always. So after that, we need to start with longitudinal bony cut. As you can see here, the red line in the alveolar bone after the full thickness flap. You can tell it's full thickness. You can see the pale pink epithelium and the darker red color, which is the periosteum layer. So both layers of the soft tissue, the periosteum and the epithelium, are elevated off the crest of the buccal surface of the alveolar bone I mean, you need to elevate quite a bit. You want to appreciate as much of the alveolar bone as possible, the trajectory of it, as you are placing, as you are going to perform this procedure. As you're going to see in a minute, it's very important to see the trajectory of the alveolar bone to do this procedure right. So we numb the patient, we open full thickness flap. As I said, the flap should be a good 10 to 15 millimeters on each side beyond the area that you are splitting. In fully edentulous cases, we are talking second molar to second molar. Step number 3, one more time, is the alveoloplasty, not necessarily 100% needed. And now we're going to start splitting after we are satisfied with how flat and how thick, again, minimum 4 millimeters of the alveolar bone at the crestal level. And we already verified with the CT scan that the alveolar ridge resorption pattern is appropriate for this procedure. By doing a little bit of alveoloplasty, by splitting, we have adequate amount of bone to place implants simultaneously, hopefully, and they are stable enough to also integrate. So how to split the bone? For many, many years, I was doing it with the 699 XXL carbide on a surgical handpiece, 45 degree with rear exhaust. However, nowadays, we do not do that, and we use piezosurgical unit. I use the piezosurgery machine, very powerful, cuts very fast, and the main reason is it does not remove any bone, unlike using a burr. So no matter how good you are, even if you do only a couple of passes in the alveolar crest to create that bony longitudinal cut from sinus to sinus or slightly beyond, you would still be removing more bone, compromising the chances of good initial stability, which is extremely required for osseointegration to take place. So we do that, and obviously the best thing to do here is using piezosurgery, as I said. The longitudinal bony cut should meet certain requirements, slightly toward the palate, so not dead center, but as you can see in the illustration, I asked the illustrator to put that line slightly, just a hair toward the palatal side. Now, because when you are expanding the alveolar ridge, the alveolar bone, in reality, you are only moving the buccal half of the alveolar bone. The palatal half is not going anywhere. It's connected to the hard palate, and it's really not going anywhere. You might think you are expanding it, moving it, maybe a hair, maybe very little. So accordingly, we do not want the buccal half to be too thin. Okay, it has to be deep enough, that bony longitudinal cut. You can go well beyond the length of the implants intended to, that you intended to place. No problem. The piezo surgical tip, it's like a blade, so that would not affect the initial stability of the implants. All the way around, the deeper the bony longitudinal cut, the longer it is mesodistally, the less chances of cracking that buccal plate, the higher chances we have less stress on the buccal plate, the higher chances we have less complication with the procedure. So, and then we need to make sure that this longitudinal bony cut is very well connected from A to Z, from the most mesial to the most distal, of that area we are expanding. And then, as you are placing the burr or the piezosurgical tip, which again, I highly recommend using the piezosurgery as not to remove any bone and do more precise cut, you need to make sure the blade is placed along the trajectory of the maxilla. So you can see the maxilla is going this way, and the red line, the longitudinal bony cut, also going 100% exactly with the same angulation, if you will. That's what I mean by the trajectory of the maxilla. So now, after numbing the patient, and after elevating full thickness flap, and after flattening the ridge, and after using the piezosurgery, and following those few rules for the longitudinal bony cut, deep enough, long enough, as deep as possible, all the way to the nasal floor, no problem, all the way to the sinus floor, no problem, even if the implant's not going that far, and as distal, as mesial as possible, very well connected along the trajectory of the maxilla. Now, next step would be to expand the maxilla. Again, there's two different ways of doing this. Just like with the longitudinal bony cut, you can do it with a burr, or you can do it with the piezosurgery. Piezosurgery would be much better. In this case here, you can do either hand chisels, which we did for a very long time, but now we have a machine that is available to us that has more control and dissipate the energy of the strokes much better than your hand and the mallet. So for that, we use now a magnetic mallet. I've been using this for only a few months. I know it's been around for longer than that. But for many years, we use the hand chisels. So you put the hand chisel and you tap with the mallet until the round portion, after the flat screwdriver portion, if you will, of the chisels, expansion chisels, reached that round portion, as you can see here, just immediately after the flattened area It's like a flat screwdriver, yes? So after the flat portion, you can see rounded portion. And that rounded portion is 3 millimeter in diameter, or 4 or 5 or 6 happens in this particular brand. But again, I recommend these days the magnetic mallet for better control and less, where you have control over the power of the strokes, but they are, the machine does more gentle job. Okay, so now you are done with this. Now we need to place the implants. I have to make very clear that if you use only the 3 or 4 millimeter chisels, again with the magnetic mallet, up to a certain width chisels, same thing, you will still be able most likely to place implants simultaneously and with adequate amount of initial stability for successful osseointegration. Otherwise, if you expand quite a bit, the maxilla would not be elastic anymore. It will not close back, and you will have to put bone graft, membrane, release the flap, suture, and obviously placement of the implants would have to be delayed by 4 to 5 months until the bone grafting took osseointegrated, and now you can place implants. So of course, it would be better to do implants simultaneously because you won't have collapse in the alveolar ridge expansion that you just achieved. If you don't place implants, you will have collapse of minimum, I would say 30% of what you gained with this procedure. If you place implants at the same time, obviously it would be impossible to have any collapse, and it is the better way to go. But it's not the end of the world. If somehow the implants are not stable, then obviously you cannot place them. They have to be stable enough for them to also integrate. So now we did expand the alveolar bone. Accordingly, suturing and having primary closure without tension is not possible unless you release the flap. So we are going to release the periosteum layer. After that, I will put cover screws and bone graft all between the implants and put collagen membrane. I might put long-lasting membrane if I have some cracks on the buccal plate. Otherwise, just collagen membrane, and you will suture now, and you must obtain primary closure without tension. This is a must for all bone grafting procedures. I can think of only one exception, which is socket grafting, but other than that, is an absolute must that you achieve primary closure without tension when you are done with any bone grafting procedures in order for you to have a good chance of success with the bone grafting procedure. Otherwise, incision line reopening after the procedure will most likely compromise the outcome of the bone grafting procedures that you perform. Any bone grafting material would do. I like to use either BioOss by itself, xenograft, or a combo of xenograft and allograft. But I would say any bone graft material would do, because the importance of the bone graft material has to do with the amount of autogenous blood available in the area. So when you are performing socket grafting, any bone material would do, because if all the walls of the socket are intact, you have bleeding, osseous bleeding, meaning full of osteoblasts and mesenchymal cells or stem cells that did not differentiate yet, and they will differentiate into osteoblasts because of the peer pressure from tons of osteoblasts around them. Then it's not important really what bone grafting procedure, what bone grafting material you would use. So the importance of using high-end bone grafting materials and the use of PRP, for example, all those has to do with the amount of the available osseous blood in the area of the bone grafting procedure. In the sinus lifting through lateral window, it's very poor. That's why it's extremely important to use PRP as you are doing sinus lifting through lateral window. But a procedure like this one here, we did longitudinal bony cut. We have tons of bleeding in between those implants. And as you're gonna see, especially in the video, And accordingly, to be honest, any bone grafting procedure would do. I like BioOS. I can add to it some allograft. Do I really need PRP? It's always plus. There is no need for it. Do I need PRF? It's a plus. I really don't need. There is no need for it in this particular procedure. Highly recommended in other procedures. And now we obtain that primary closure by, as you can see here, releasing the periosteum layer. And having a primary closure using PTFE, suture material, etc. You have to pay attention to the provisional prosthesis. Most likely the existing one would not fit. You have to fabricate a new one, most likely, 99% of the time, because of the expansion. And if the implant are 4 millimeters, then you're expanding minimum 4 millimeters. How the existing denture will fit? Not possible. So you will take a digital scan or alginate impression and start to fabricate quickly a new denture, because immediate loading with this procedure is not indicated. You already performed one miracle. So immediate loading or even one-stage protocol, I do not recommend. So you expanded the ridge and at the same time you placed implants. That's enough. Now we're going to put cover screws, bone graft, membranes, primary closure, and we are going to wait 4 to 6 months. And then we will be restoring these implants. So due to time, we're going to move a little bit and we'll look at a few cases. So this is a case where I expanded quite a bit. Placement of implant at the same time is not possible. So full thickness incision. This is a very old case. I have newer cases coming in a second. And you can see here some alveoloplasty because it's a knife edge on the left-hand side very clearly. You can see a knife edge crystal bone. And after some alveoloplasty, back then, I'm not sure if piezo surgery was even around. I don't think piezo was invented. I'm like 99% sure in this particular case. So we had no choice but to expand using carbide burrs, tapered on a surgical handpiece, of course, as to minimize the chances of causing any soft tissue edema with full thickness flap open. And after a few chisels, as you can see, knife edge crest turned to almost 10 millimeter wide, but again, impossible at this point to place implants at the same time. The maxillary bone is not that elastic. So you put bone graft, and this is a combo of BioOS and allograft, so xenograft and allograft, if you will, and membrane and primary closure after releasing incisions are made. Later on, I placed implants for this patient, and this is before and after. And a few months later, we did 8 implants. I lost 1. I still remember this case. So, but still, we have 7, and that's plenty to proceed without any additional implants. This was spark erosion case. Nowadays, we call it Marius bridge, the CAD/CAM version of this prosthesis. This is the verification jig, as you perfectly know, just to verify that the implant analogs in the cast do match 100% the location of the implants in the mouth. So this is the spark erosion, no palette, no acrylic palette, as you can see, and you have the intimate contact of the metal housing that is inside the dentures on the bar. Another case here, same thing. This procedure is designed only for the anterior maxilla, in between the sinuses. So it can be, 20 millimeters or 40 millimeters. So you are limited by the sinuses unless you do at the same time sinus lifting through lateral window. So again, this is the using the burr days, and as you can see, knife edge was able to now accommodate implants with this procedure. And after placing the implants and the cover screws, you put the bone graft in between them, and of course membrane, as you can see here, releasing the flap and place the implants. This is even before All-on-4. With All-on-4, I could have gained a little bit more AP spread, obviously, with the distal implants. But neither piezosurgery nor All-on-4 was invented, if you will, back then. Another spark erosion on the upper and the lower in conjunction with soft tissue support in the posterior in this particular case. Another case, and this is where crown and bridge was attempted, and it is acceptable, but again, this really procedure indicated when the final prosthesis is hybrid. This is expansion with 9 implant placement at the same time. Few months later, some exposure of cover screws, but there was no issues there. None of these implants were lost. After 6 months, healing, abutment stage. Impressions. And this again was for crown and bridge work that I really not sure I would recommend, because you will have much better aesthetic outcome than this when you do a hybrid. But that's what the patient wanted, I guess, and she had low lip line and she was very happy with the outcome, actually. So we had these teeth supported with 9 implants, and this was successful for a very long time. Another case here where we did simultaneous ridge expansion and implant placement and sinus lifting through lateral window on the maxilla, all that at once. Look at the left-hand side image, and you might think you have plenty of bone. However, after flap, as you can see here, I opened full thickness flap, and as you can see. As you can see, this patient is in need of expansion. Placement of implants is impossible unless you do one grafting procedure first. So for the anterior, I did the expansion here. You can see you elevate flap all the way to the nasal floor. You can see the aperture of the nose on the left-hand side very clearly. You want to appreciate completely the crest and as much of the trajectory of the maxilla as possible, as not to thin too much the palatal plate or buccal plate as you are expanding. And here again, this case with simultaneous sinus lifting through lateral window. Membrane for the inside, bone graft 50-50 with PRP in this case, BioGuide by Geislich on the outside, and then bone graft material again between the implants, membrane, and primary closure with no tension using PTFE. And this is the final panel, if you will, after expansion, bilateral sinus lift, and 4 implant placement. This happened to be partial a case. So some teeth needed to be extracted here, and I expanded the ridge from the most distal socket of extraction socket on the right hand to the left hand side one. And of course, placement of these 5 implants. And after expansion, after implant placement, you can see here the primary closure at the end. Case number 6 here, same thing, partially edentulous. Look here, there is no need for alveoloplasty, full thickness flap, retracting sutures, very important as to really appreciate the alveolar bone, shape, trajectory, etc. You can see here the longitudinal bony cut. You can get very close to a tooth, as close as 1 millimeter. And after that, we are using the chisels. The edentulous span, in my opinion, was adequate to perform this procedure on this particular patient. Implants are placed. Cover screws are placed, bone grafts, and membrane. And then releasing the incision and primary closure. Last case, this is what I would like you to start with. It's fully edentulous patient, so less chances, in my opinion, of complications, shorter learning curve, because the longer the longitudinal bony cut, the less chances of problems, because the alveolar bone will be more elastic. So this is full thickness incision. Full thickness flap, alveoloplasty, piezosurgical tip for the longitudinal bony cut, maybe a hair toward the palate to have thick, as thick as possible, buccal bony flap without thinning too much the palatal one. You can see how much bleeding points, if you will. So any bone graft material would do, because you can see the crazy amount of osseous blood available in the surgical field inside the bone where the implants and the bone graft are going to go. Absolutely must use tapered implants. So something like Noble Biocare Active is absolutely not indicated. I like to use Noble Biocare Replace tapered in conjunction with this procedure. Healing abutments are not okay. Immediate loading is not okay. It does not matter what is the initial stability. In this procedure, you only do cover screw and you only do two-stage protocol. All implants are placed. There must be roughly full millimeter under the buccal crestal bone level. Bioos, collagen, tape, releasing the flap, and primary closure. So this is it. We do not have much time for video, but nonetheless, I'll probably run 5 minutes video very quickly. Of book is the alveolar ridge width. So you can see here with the CT scan evaluation of the CT scan, we can see that we have plenty of height. This is fully edentulous patient. And the resorption pattern is okay, is more than okay to perform this procedure. So we start with incision. The most implant that we are planning to place on each side. And now we're doing full thickness flap. The anterior, you do not want to be very aggressive. This definitely sets the tone for the rest of the surgery. 40,000 rounds per minute with. So after numbing the patient, after full thickness flap, now we're doing the alveoloplasty portion, if needed. In this case, was needed. The alveoloplasty burr and plenty of irrigation. But again, the minimal amount of bone loss of bone should be removed rather to perform this procedure to get the job done. Case here, we would use electrosurge to. So here we are done with the alveoloplasty. Next step would be to use the piezosurgical tip. You can see in this particular scenario, since it's fully edentulous, plenty of areas where we can place implants. No need really to perform incisive canal deflation, although again, quite often we do that simultaneously with this procedure. Incise the it, and you would not lose any bone, because to start with, we don't have enough bone, and that's why we're doing this procedure. So it's important to, in my opinion, to invest in piezotome, because there's a few bone augmentation procedures that do require piezotome. All right, so now the goal is to, so otherwise you have to pay attention to that, and then by the length of the implants you are planning. So it's better not to go with this, edit it down to 30 minutes, but it was just a little. So here we go. Now after the piezo surgery, now in this case we are using hand chisels. Now I do not do that. I exclusively use magnetic mallet, but this is this is how you place and use hand chisels. Chisel, expanding chisel. And you can see, again, you place it along the trajectory of the maxilla, and with the mallet, you tap and you go to at least 10 millimeters if the implant is 12 millimeter long, all along the ridge, all along that longitudinal cut that we created with the piezotome. And notice how I'm removing the expanding chisel after I introduce it into the bone with the mallet. You shake the chisel mesodistally. You don't shake it buccolingually as not to expand or fracture the buccal plate of the maxilla. The expanding chisels usually come in a kit, and this kit 3 or 4. So now we start placing implants one at a time, and you will see the bone is expanding as the implant are going in. If you did the right amount of expansion, if you did not go over the amount needed, because as I said, that will compromise the initial stability, and it's not the end of the world. That's okay. You can do the procedure over 2 steps. It's no big deal. I mean, the patient would have to wait 4 more months, but it's not the end of the world if somehow you expanded during your learning curve on some occasions the alveolar bone to the point where you cannot place implants simultaneously because the initial stability now is inadequate. So now placing all the implants, as you can see here, and putting bone in between, and then membrane. Any bone grafting material, any usually after the procedure you would have. Now this is all the time we have for today, and I would love to take your questions now. I have a few questions here. I have a question here. Do you ever consider using densa burrs to further widen these along with the split? The answer is no, totally not needed. If you're using this procedure and just like the way you saw, some alveoloplasty if needed, and piezosurgery, and then magnetic mallet, I really don't think there is a need whatsoever for densa drill. We under prep anyway, and I don't think it will hurt, but I don't think it will be beneficial. Another question, discuss a single site. For single site, this procedure is not indicated. For even 2 or 3 or 4 sites, I think this procedure is still not indicated. To expand the alveolar bone for a single site, you would have to do either block graft or particulate with membrane, or maybe particulate with titanium mesh. But this procedure definitely is not indicated as the maxillary bone is not elastic enough. You would have to do different procedure. You can do pedicle sandwich plasty that we do for the mandible, for the maxilla, if it is single site, but definitely not split cortical technique. Another question here, could DENSA versa burrs be utilized? Yes, but I don't think they are beneficial, nor I think they are designed to be used in conjunction with this procedure. And if you want to use them instead of this procedure, I don't think they do as good of a job than the classic alveolar ridge expansion with the split cortical technique. I mean, you just watch the video, you watch many cases. I don't think DENSA will be capable of providing the same results when this procedure is indicated. Although they are very beneficial in other scenarios. Do you do osteotomy using drills after expansion prior to implant placement? Yes, absolutely, but you need to under prep. That's from Dr. Sadati. A question by Dr. Diamond asking to introduce the mandibular technique. Unfortunately, no time for this. I would love to do a webinar with the ICOI on the mandibular expansion technique, which is the pedicle sandwich plasty, and we can spend an hour talking about that, and it would be my pleasure. Question asking about the minimum ridge width required to perform this procedure. Again, when you place implants, you would love to have 2 millimeters of bone thickness on the buccal and lingual or palatal of the implant. So it would be nice after minimal alveoloplasty to gain 4 millimeters. Type of implant thread configuration you prefer in this cases absolutely must be tapered implant. So as I said, aggressive thread implants are absolutely not good idea to be placed simultaneously with this procedure. If you do only bone grafting expansion using this procedure and then you want to place implants, of course you can place any type of implant. There is no limitation whatsoever, but simultaneously to do implants, you do not want something like Noble Active. You do not want something like Noble Parallel even. You want threads that are not too aggressive and definitely tapered implant. Can the patient wear all dentures? I think I mentioned that. 99% are not. If they are able to wear the old dentures, that means you did not expand enough. So chances are not. Any vertical cuts from a doctor, if the cortex is very dense and thick, but still require this procedure, it's nice to do some vertical cuts in order not to fracture, in order, in case of any fractures, not for these fractures not to go too far. Let me take a couple of more questions here before we wrap it up for today. What is the minimum inter-implants distance? Very good questions. Well, as I said, these implants with this procedure really not for crown and bridge. So the minimum is should be enough to put comfortably 2 abutments to restore with whatever you are doing, hybrid or bar or locators. So edge to edge, let's say 7 millimeters edge to edge would be definitely adequate for any kind of abutments you will be utilizing on the top of these implants in the future. Management of fractured buccal plate. If it's not loose, you can simply put bone graft and membrane. If it's loose, you have to fix it with screws. I have some doctors here commenting that they love their magnetic mallet. Well, I love it too. There are some requests from Australia to do a ridge split for the mandible webinar, and that would be my pleasure. This would be it for today. I would like to thank the ICOI. I would like to thank Dr. Eddie Palti for the invitation. It was my pleasure and my honor to be with you today, and looking forward to more webinars in the future, and would like to thank you again for your kind attention. Tara, you want to take it from here?
Sure. Thank you very much, Dr. Al-Faraje. We appreciate you being here with us today. A great presentation. Dr. Palti, thank you as well for introducing earlier. Did you have any comments?
Well, I want to thank Louis for a fantastic presentation. I want to thank the participants for joining us. And I'm sure we will have another presentation on the mandible, as I heard. And we look forward to have those webinars on a regular every 2 weeks. So look at your emails, look on our ICOI Facebook, and we will have a lot of interesting subjects in the next few weeks. Thanks, everybody. Hope to see you face-to-face sometimes, but we don't know when. So have a wonderful day, evening, weekend, whatever. And Louis, thank you very much for a great presentation. And
thank you.
Stay tuned and stay safe, everybody. Thanks you, Tara and Ale, for your efforts. Bye.
Okay, bye-bye, everybody.
Bye-bye, everybody. Thanks.